Let's get the ball rolling. Ready? Ready? Okay. Zoom again. Go. Okay. So let's get inspired. Let's begin our session 2 with inspiration. Okay. Now, here's actually an NCLEX passer from Cebu, Jeneline Ruiz, who passed the State Board of Texas test. And here's her story. Initially, I wasn't planning to review in any center because I was thinking that only a few days will be left on my 6-week vacation. My friends and family were telling me that they are confident with my theoretical knowledge since I am studious. I have a background in teaching. However, I told myself I don't want to give myself a reason to point at just in case I don't pass. I decided to enroll in a review center. I graduated 10 years ago. I have been a NICU-PICU nurse for almost 10 years. Being Gapos baby is a big help. Even if you have read and answered millions of reviewers, Gapos will be the one to guide you on what you should focus on and what you need to master. That's why we're doing the quick fix. Remember, the quick fix is different from final coaching. Final coaching is broad. Quick fix is very, very specific, just on what you need to remember. But take note, class, the quick fix is only good for the next 30 days. So does that mean, sir, magkakaroon pa tayo ng another quick fix after 30 days? Yes. And I would discuss the new trends again. Okay? So keep yourself glued on our quick fix, okay? But I'm sure because of some requests, the next quick fix would be on a weekend. It would be on a Saturday. So you can mark down your calendar. It's going to be October 3, the next quick fix. So September is for those who are taking the test September. The October quick fix would be for those who are taking the test October, okay? And if you plan to take your test next year, so attend my quick fix every month. Okay, I wouldn't be, I would love to have you here because I know when you're thirsty for knowledge, that's the best time to learn, okay? So thank you for the kind words. Coming from our pastors, the lecturers are very knowledgeable. That's why I really look up to them, okay? So here's an NCLEX quick fix test taking key, okay? Failure is an ingredient of success. So it is not different from success. Failure is not the opposite of success. Failure is part of success. So fail as many times as you can. What matters the most is eventually, when the time comes, when God gives it to you at the time when you can best appreciate it, that's the time you will have it. And I will be there with you, okay? So let's move on. Success is 99% failure, as they say. So don't be afraid to fail. So whatever it is you're doing now, don't be afraid to just dive in. Dive into our second session, okay? So the first session is a bit long. Second session is longer, okay? The second session is longer, okay? So I just hope you could give me your full undivided attention again, okay? Thank you so much for finding the time. I hope I'm making your time as meaningful as possible, okay? I'd like to empower you to pass those tests, okay? So let's begin with something that's sometimes forgotten to be studied, okay? So this is about fat embolism, okay? Anything about fat reminds me of my former self. You know what? I used to have like 44-inch waistline, okay? And I slowly work on that. Of course, I'm one person who really wants change immediately. So what I did, of course, I asked my friend, Dr. Vicky Bello, to do some lipo. And from there, I have to have diet. Okay, so I was able to maintain my waistline from 32 to 34, okay, at most, okay? So if you are that type of person, after the pandemic, okay, try to figure out some treatments to become beautiful again, okay? Well, you can just jog around your area. It don't have to be expensive. But on my end, I was younger then, so I wanted the change to be immediate. I did a lipo, okay? You can ask me about those surgeries, okay? You can ask me about what Vicky did to my hair, to my cheek, so that's gonna be thinner, okay? What she did to my jaw. You can ask me in the chat. You can send me an email, okay? You can ask me, sir, can you schedule me for a consultation? I would text her for you guys. Okay, anyway, let's talk about fat embolism. The first thing that you have to remember when you're studying a concept is, remember, the NCLEX usually deals with reflective questions. So what will the nurse prioritize for a patient with fat embolism? So what should be your priority? Remember this big letter O in the word embolism, because that's your priority. The priority is oxygenation, okay? So when a patient has fat embolism, you have to administer oxygen, fluids, and heparin. Why oxygen is the priority? Because it decreases the surface tension of the fat globules, decreasing the chest pain, okay? In other words, okay, after you have administered oxygen, what do you need to validate? The next thing, what could have caused fat embolism? Okay, now, history would tell you that patients with fat embolism have had history of what? Broken bones. Not broken vow, okay? Broken bones. Now, what specific bones? Usually, these patients will have fracture of the long bones. So you say fracture of the femur, fracture of the tibia, and fracture of the pelvis. The question is, can we prevent fat embolism? Yes. How? By having surgical correction of the fracture within 24 hours. Because the longer that you keep the fracture untreated, the higher the risk for fat embolism. Okay? Now take note. What symptoms would usually tell you that there is fat embolism? There are two groups of symptoms, and these are used. Remember, on the NCLEX, you have to have a syndromic approach to understanding data. Syndromic means you are creating a diagnosis in your mind. Okay? So the two groups of symptoms are called GERDS criteria, G-U-R-D-S. So you have major GERDS criteria and you have minor GERDS criteria. Okay? Fat embolism is considered present when you have one major criteria and 4 of the minor criteria. So what are the major criteria that we can consider as indicative of fat embolism? The first one is the big letter P, petechial rash, okay? But remember, the NCLEX is very layman. You wouldn't see petechial rash on the test. What you will see would be bluish, okay, patches. Those are the description. Bluish patches, bluish brown patches on the skin, bluish brown patches on the chest. So that's actually petechial rash. And then you have respiratory distress. So aside from petechial rash, you have respiratory distress and mental concussion. If there's any one of this, usually the most pathognomonic of fat embolism is the petechial rash. And it's very acute. It occurs within the first 12 to 72 hours after the fracture. And it's usually coupled with the respiratory distress, in which there's going to be rapid breathing or shortness of breath, okay? So any of those three, any one of those three would tell you that there could be fat embolism. Once again, petechial rash described as bluish or purplish patch on the skin, respiratory distress, and mental concussion, okay? Now, what are the minor GERDS criteria? You have to have at least 4 of the minor GERDS criteria. Okay, out of the 6 GERDS criteria, okay, 3 of these begin with the letter F. Okay, the 3F of fat embolism. The first one is fever, okay, fat in the blood, and fast heartbeat. Fever, fat in the blood, and fast heartbeat. Okay, the 3F. Then you will have the next 3 symptoms, the next 3 minor GERDS criteria would be the code, would be contained in the code JAR, J-A-R. J would be jaundice or yellowish discoloration of the skin. A would be anemia, okay? A would be anemia. And last but not the least, okay, when your patient would have renal dysfunction. So renal dysfunction. Once again, jaundice, anemia, renal dysfunction. The 3F, fever, fat in the blood, and fast heartbeat. So if you have 4 of the 6 minor criteria plus 1 major criteria, then chances are the patient is indeed having fat embolism. Okay. Let's welcome back some of our I'm sorry, colleagues back in. Okay, I'm doing multitasking now. So I am the one who's actually controlling the entry. Okay, thank you. Okay, okay, let's go back. So fat embolism is a serious complication of, take note, long bone fracture, could be of the tibia, the femur, or the pelvic bone, characterized by shortness of breath, which occurs within 12 to 72 hours, increased heart rate, tachycardia, then increased breathing pattern, tachypnea, petechial rash, okay, bluish or purplish patch on the skin, on the back and the neck, okay? So petechial rash is pathognomonic of the condition, and if this is coupled with shortness of breath, and then fever, then anemia and jaundice, then you have fat embolism. Now, what if the test would ask about a SATA question? Select all that apply format of multiple choice question. So my take is that remember the GERD's major and minor criteria. Focus on the symptoms, okay? Next. Oh, let's talk about Wilson's disease. Okay. Now, the presenting symptom of Wilson's disease would be something like that of a patient with liver cirrhosis. And that's why they usually present some concepts related to questions that covers differential diagnosis. Okay, when you're trying to differentiate patients with liver cirrhosis from other forms of diseases, this is one of the considerations, Wilson's disease. Okay, so let's have a simple question. A 7-year-old patient is admitted due to fluid buildup in the abdomen. Assessment reveals rusty brown ring around the cornea of the eyes. Okay, let's deal with the first sentence. Admitted due to fluid buildup in the abdomen. So you have here ascites, you have ascites. So what is the first thing that comes to mind other than yourself when you know there's fluid buildup in the abdomen? There's usually liver failure, right? And if you think about liver failure, the first thing that comes to mind would be liver cirrhosis. But look, class, let me just again admit one client, okay? But look, class, the second sentence says, assessment reveals rusty brown ring in the cornea of the eyes. You don't have that in liver cirrhosis. The rusty brown ring could sometimes be bluish ring, could sometimes be greenish ring, and this is actually due to mineral deposits, specifically copper, okay? And this ring is called the Kayser-Fleischer ring, which is actually pathognomonic of a client with Wilson's disease, okay? So this type of question is what we term as syndromic presentation of data. You don't have a diagnosis and it's being asked of you, okay? Okay, so the answer here would be Wilson's disease. Okay, now light chain deposition disease is the opposite of immunosuppression. Okay, light chain deposition disease is when you have hyperactive immune response. Okay, that creates usually an accumulation of light chains that eventually accumulates in the kidneys and may damage the kidneys. Para kang nag autoimmune reaction sa kidney. That's light chain deposition disease. Okay. Hi, Bimala. Okay. We're having our Indian friends. Okay. So, for us to learn what Wilson's disease is, okay, let's identify the characteristics based on this question. The nurse knows that Wilson's disease is characterized by which of the following statements? Select all that apply. It is caused by a faulty diet. You know what? Your Wilson's disease is not primarily caused by a faulty diet. It is genetically transmitted. You cannot change what's in the gene. So this is an X. It is more common in men? No. Okay. There's usually equal chance. Lifetime treatment is necessary? Yes. because it is genetically transmitted. Now, since there is accumulation of mineral, the element copper, so you treat this as if the patient is having lead poisoning. So you have to administer medications that would facilitate the excretion of copper, like penicillamine and triantine. Yes, okay. And then, since this is genetically transmitted, refer all family members to the geneticist for genetic testing. Okay? And take note, if it doesn't work, what happens is that liver transplant is a treatment option. Now, what makes the statement wrong here on that item is that it says it's not a treatment option. It is a treatment option, so we put an X. So, what do you need to know about Wilson's disease? Everything that we have integrated in this question. And always remember that Wilson's disease sometimes side by side is being asked related to liver cirrhosis. Okay? So every time you get to see big belly, there's accumulation of fluids in the belly, think liver failure, think liver cirrhosis, but don't forget also to think about Wilson's disease. What differentiates Wilson's from the other one? The Kayser-Fleischer ring. It's the bluish or the brownish or the greenish ring that occurs around the pupil, and it's due to accumulation of copper. Okay, so Wilson's disease is transmitted through an autosomal recessive pattern, meaning it equally occurs in both men and women. Okay, so it's transmitted when both parents carry the trait, and there's 25% chance that their children will have the disease, both men and women. Okay, next, the drug Clozapine or Clozaril. Now, what is Clozapine or what is Clozaril? Clozapine is an atypical antipsychotic. So we administer this to clients with schizophrenia. Now, we know for a fact that there are two groups of symptoms when you talk of schizophrenia, right? The positive symptoms and the negative symptoms. I'll discuss that later on when we go to schizophrenia. Now, the difference of Clozapine from typical antipsychotics like Haldol is that your haloperidol only would target the positive symptoms. Okay? Clozapine, however, targets both positive and negative symptoms. So if we compare Clozapine and Haldol, we can therefore say that Clozapine has more encompassing effects than Haldol. Okay? However, well, the disadvantage of Clozapine is that it requires weekly monitoring of the white blood cell or ANC levels, okay? And it is expensive, okay, doing the laboratory test, okay? Remember, I'm not taking Clozapine, but I'm taking like a dietary supplement that requires me to take my blood test. And one time I was at the facility in California, and they were asking if I have an insurance, and I said, I'm just a tourist, I don't have any. You know what? The basic blood test that we paid for like 1,500 or 2,000 pesos in the Philippines cost me $200 in the States. So you can just imagine if a patient doesn't have an insurance and the patient's taking Clozapine and they have to have a weekly blood testing, so that would really cost so much, okay? So, of course, you don't want to become crazy. You don't want to become schizophrenic, okay? Because other than manifesting the symptoms, you would also have, okay, you know, wasted savings because medication is just too expensive, okay? Okay, so let's move on, okay. So here's a functional concept. Clozapine causes neutropenia. It is essential, therefore, to monitor the absolute neutrophil count, and the WBC count is usually monitored every week. So severe neutropenia occurs when the ANC is less than 500 units per liter. Okay, the normal range for ANC is equal to or more than 1,500. So whenever there is less than 1,500 ANC, you need to refer the client to the healthcare provider. So ANC monitoring for patients receiving Clozapine should be monitored weekly for the first 6 months, every 2 weeks from 6 to 12 months, and then monthly after 12 months. So the key is you always have to inform the patient that if they are taking Clozapine or Clozaril, they will have to check on the WBC or the absolute neutrophil count. Okay? Okay. Now let's move on to one of the most common types of cancer that occurs in both males and females. You have your breast cancer. Now, a lot of students are asking me, what will I study in relation to breast cancer? Will I study the laboratory test? Will I study the self-breast exam prevention detection algorithm? Will I have to study the chemotherapeutic agents? Well, there's one thing I'd like you to master. No matter what, remember the risk factors for breast cancer. Okay? Just the risk factors. Okay? So here's a functional concept. Risk factors to breast cancer includes, remember the code cancer, contraceptives, okay, advancing age. Now, those who are actually 50 years old and above are at risk. Okay, nulliparity, those who have not been pregnant, or those who have reached the age of 30 before they had their first pregnancy. Cancer in a first-degree relative, and early menarche and late menopause. Don't ever forget this. Early menarche, the patient started menstruating earlier, and the patient had a late menopause, okay? Well, usually the average age of menarche would be 10 to 12 years, and some, if they had menarche as early as 8 or 9 years old, that could be a risk factor to breast cancer. Late menopause, the average age for menopause would be 40 to 45, and some would have menopause at age 50 or 55. Late menopause could be a risk factor to breast cancer. Then replacement therapy with estrogen and progesterone. What used to be just a controversial factor, and it's not pinpointed as a positive or potential risk factor, has now been categorically included as a risk factor of breast cancer. That is the use of estrogen and progesterone pills. So people who are taking pills, or people who took, who had estrogen replacement treatment, okay, to deal with the hot flashes after menopause, could be at risk for breast cancer. So remember our code, cancer, okay? Now, when there is average risk for breast cancer, perform self-breast examination. If you are between age 20 to 34, monthly, and clinical breast exam done by a trained professional should be done every 3 years. From age 35 to 39, monthly. Clinical breast exam should also be done every 3 years. But when you turn 40, okay, apart from the self-breast exam monthly, you also have to do the annual mammogram. Now, let's adopt the what-if mentality again. Okay, what if what was asked is you have a patient who has an average risk for breast cancer, but this time, okay, the patient is no longer menstruating because the patient had total abdominal hysterectomy with bilateral salpingo or oophorectomy. Remember that self-breast exam is usually done a week after menstruation because the hormones are decreased, therefore the breasts are less tender. Okay, so it's easier to palpate the breast. However, in a patient who is no longer menstruating, would they still need to do self-breast examination? Of course. But since they're no longer menstruating, when is the best time for them to do it? Ask them to choose a specific day in the month that they have to do the self-breast exam consistently. Okay? Regularly. They have to be religious about it. And self-breast exam is not just for females. Even males should do that. And the most common site where tumors are usually found would be on the left upper outer quadrant of the left breast. Okay, that's called the tail of Spence. Tail of Spence. Okay, sorry. So when there is high risk for breast cancer due to family history, take note, the presence of a family member who had breast cancer qualifies you to be at high risk. Therefore, here's a question. I'd like to clarify this for you guys, and you have to take note of this. So who should be the priority for breast cancer screening? Is it the child who hit her breast, okay, with a ball while playing baseball at age 13 and is now 25? Or is it the girl whose 25-year-old sister develop breast cancer, remember this concept. The presence of family history qualifies the client as high risk. Okay? So if the patient therefore is high risk, instruct the patient to start doing self-breast exam at age 20 because at this time, the breasts are already believed to be fully developed. Those of you who are now 20 and have yet to fully develop the breast, don't feel bad about it. Still need to perform the self-breast exam. Clinical breast examination is done by a trained professional every 6 months, starting 10 years before the age at which the youngest family member was diagnosed. Let's give meaning to this. If the youngest family member was diagnosed at age 25 with breast cancer, therefore, 25 minus 10, start doing the clinical breast examination at age 15. That's what the guideline says. Okay? Yung pinakabata na diagnosed at 25 years old, deduct 10, so 15. Doon siya mag-umpisang mag-clinical breast exam by a professional. Next, annual mammography starting 10 years before the age of the youngest family member with breast cancer was diagnosed. Same. So if the patient's sibling was diagnosed at age 25, you deduct 10, and that would actually qualify you, okay, to do the annual mammography beginning at age 15. Okay? Ang aga, sir. Because, you know, you are at risk when you have family history. So, the most important risk factor, therefore, of breast cancer would be family history. So whoever has had a history of breast cancer in the family should be the priority for breast cancer screening. So BRCA1 and BRCA2 must be identified. Those are the tumor markers, okay? Now, there is also high risk for breast cancer due to a diagnosis of benign breast disease. Okay, or when there's breast cancer that's confined to milk ducts. If that happens, do the self-breast exam at age 20, clinical breast exam every 6 months, and annual mammogram starting at the time of diagnosis. This time, this refers to the patient, no longer to the sibling. Because if you're referring to the siblings at the 10 years after, okay, the diagnosis of the youngest sibling. This time, 6 months starting at the time of diagnosis. You're referring now here to the patient, no longer the sibling, okay? So, in men, risk factors for breast cancer include look fit, okay? That's a code. Liver disease, old age, obesity, Klinefelter syndrome, family history of breast cancer, exposure to estrogen, testicle disease, or surgery. Okay. Let me highlight here Klinefelter's. Okay. Now, what's Klinefelter's syndrome? Klinefelter syndrome is a chromosomal abnormality characterized by the presence of an extra X chromosome. Now remember, in the normal male and female, you have an XY chromosomal combination for boys and an XX chromosomal combination for girls. What happened in Klinefelter syndrome is you have an XY and then an extra X, such that the pattern has become XXY. So what happens? You have a very tall patient, very tall, very skinny, with non-development of the secondary sex characteristics. And that is due to the presence of the X chromosome. Therefore, you have a very tall patient whose sexual organs have not fully developed. That's the problem in clients with Klinefelter's syndrome. Okay, now how are patients with Klinefelter syndrome different from clients with Marfan syndrome? Okay, Marfan syndrome is genetically transmitted. Klinefelter syndrome is a chromosomal abnormality. Okay, Marfan's is transmitted by autosomal dominant pattern, which simply means it could affect males and females. Okay, now Klinefelter's only affects males. What's the similarity between Klinefelter's and Marfan's? Both are tall, okay? But Klinefelter's, you have underdeveloped sexual characteristics. Marfan syndrome, they have hypermobile extremities, which are considered as spider-like in terms of movement. That's why patients with Marfan syndromes are at risk for injury because they can't control the hypermobility of their extremities. Okay? Okay. Remember that concept. Let's move on. Now, when should screening mammography begin in women with average risk age 45 to 54. Women with high risk before age 40. Now, the American Cancer Institute has explicitly stated that screening mammography should begin at age 30 if the woman is at high risk. Okay. Now, if the patient is scheduled for mammography, what do we tell the patient? Avoid the use of lotion, avoid the use of deodorant, avoid anything that the use of powder on the axillary area and the breast area and the chest area. Why? Because if these are exposed to X-rays during mammography, the calcium oxalate components of these things like your lotion, your powder, okay, the calcium oxalate components would solidify and may give a false positive result. Now, here's a question. What if, let's have the what if mentality again. What if the woman who is to undergo mammography is using an herbal or natural deodorant? Will you or will you not allow the patient to use it? Now remember, the guidelines specifies that. Tatandaan natin, okay? So that there will be no confusion. Everything should not be applied before a mammography. So there should be no application of anything, okay? Whether that's perfume, lotion, or powder. And in fact, they have adopted a routine that if a patient is going to have a mammogram, okay, the area should be wiped until clean several times, because even sweat, if it's very high in sodium, could actually solidify and may give a false positive result in the mammogram, okay? So after the initial mammography for women with average risk starting at 45 to 54, for high-risk women beginning at age 30, they have to do this, okay, for women with average risk every 2 years for the next 10 years. But if you are at high risk, you have to do it every year, okay? That's according to the American Cancer Society. So remember, the benchmarks, self-breast exam at age 20, high risk, mammography at age 30. Average risk, mammography between the age of 45 to 54. Okay? And remember, do not apply anything on the axillary or chest part when a patient's doing mammography. Now, there's another concern. What if a patient asks you, is it painful to have a mammogram? Okay. Remember the principle of veracity. You have to be honest. But always remember too the principle that anticipation of pain worsens the patient's pain experience. So you don't use the word pain. Tell the patient you will feel a sense of pressure during the procedure. Tapos nagmura yan. Ano ba yan? Sabi niya, putay na, PI. Pressure, pain pala. Okay. Let them discover it, okay? Huwag niyong pangunahan yung experience. Allow the patient to experience the pain, but never use the label, it's painful. Tell them you are going to feel a sense of pressure. Remember, the NCLEX is very layman. Okay, so let's move on. So test-taking key, know what works for you. Now remember that when you're preparing for the NCLEX, there is no one right way. There's no one best review. There's no one best review center. I don't believe in that anymore. The best is what works for you. Okay? So I have a student. She had difficulty passing the test. I was with her for 2 years. I was mentoring her for 2 years until I ran out of strategies. And I told her, you know what? Let's play this game I created for you. Okay, so it's a game-based review. Okay, you do this for 6 months and then take the test. Let's see. She did that. After 6 months, she took the test and she passed. So the key is you have to figure out what works for you. What I might be doing right now could be judged as excellent by some of you guys, but for some it may not work. So please do tell me. If it's not working for you, I would be glad to help you out identify what works for you. Okay? Because, you know, when you're preparing for the NCLEX, it's also like a preparation for going to the gym. You have to develop your mental stamina. Okay? Okay, I'm not promoting this product, but I have to tell you a secret. Don't you know that you can take something to enhance your memory? And that something, is I discovered, is a gym supplement. And most of the students who top the NLE board under my mentorship, and those who pass the NCLEX under my mentorship, I'm giving them for free. But right now, we ran out of stock because of the pandemic. You can order it online. It's called Psychotic. But don't drink too much. Just half a teaspoon to 1 glass of water. And what will be the side effect? You would love to read and answer questions. That's the side effect. Okay, so I'm taking it. It's FDA approved, but it's approved for as a gym supplement. So I was taking it for my as my gym's part of my gym supplement. But I discovered, I said, why is it that I have this tendency to want to read more, to want to answer more questions? Why I'm taking this drink? So I just discovered it. What's the name again? Psychotic. Okay, psychotic, like a psycho, psychosis, psychotic. Okay, you can Google that, and don't overdrink. Okay, don't overdrink. But the side effect would really be you'll have very sharp mental skills. Okay, that's one thing I'd like to share with you guys. Okay, so let's move on. Oh, this is actually the picture with some of our Indian nurses who are now in the States. I'm so glad and happy for all of them. This is my co-mentor, Jem. And this is Karki, Rashmi. Okay, a lot of them now are Sajita. Okay, most of them are now in the States, scattered worldwide. I'm happy to have been a part of training more than 400 Indian nurses and help them out fulfill their great American dream. Happy to be part of the fulfillment of those dreams. I once had also those things. And just making it easy for you guys. Okay, so this is also the success story, 5 international tests, okay, for Rose Ann Victorino. Now, she just attended one session and then used that session for all her tests and licensure exams or certifications. Take note. What I would want to tell you right here is that don't discard our PDF files because you will use them again when you do your certifications in Prometric or Saudi Council or CGFNS, okay? So keep your notes, okay? And remember, I'm giving away 10 learning packages. 10 learning packages, okay? For the first 10, I would now tell you the mechanics. For the first 10 who can answer a question I will post after session 2. Okay? So after session 2, I will ask a question and the first 10 who will give the correct answer in our chat box, okay? Will get a complete learning package from me, okay? That includes my books, okay? That's gonna be for free. I will ship it to your place for free, but if you live outside the Philippines, I will send you a PDF file instead. Okay, so are we ready? Go. So let's talk about psychotic and schizophrenia. Okay. So some students are asking me, sir, cannot that drink lead to schizophrenia? Of course not. I've been taking it. Look, do I look like schizophrenic? Of course not. I'm not, right? Okay, so it's safe. It's FDA approved. Okay, ready? The first thing that comes to mind is that sometimes when we study, okay, disorders, the first thing that we bring to our consciousness would be the psychopathology, the pathophysiology, the signs and symptoms, the treatment. We memorize everything. And then when we go to our test center, we forget everything. The more we write down, the more we forget. Okay? Why is that so? Because we lack focus. So this is what NCLEX QUICKFIX is all about. I'm giving you a sense of focus. I'm trying to appeal to your senses, auditory, okay, visual, or whatnot. Okay, I'd like to highlight that. If you know which part of the concept you need to master, then it's going to be easy for you. Okay, so we know for a fact that schizophrenia, the most acceptable causation theory is the elevation in dopamine, the dopamine hypothesis theory. But it's not so, that's not what's gonna come out on the test. Okay, why? Simply because that's very technical. Remember, the NCLEX is layman's. So laymanize your concepts. Okay? So we focus therefore on the positive symptoms of schizophrenia. Okay? Now when you say positive symptoms, they are called positive symptoms because they reflect distortion of normal function. In Tagalog, kaya tinawag na positive symptoms, this is in Filipino, ito yung mga nakikita sa mga abnormal or merong kabaliwan. Pero, hindi nakikita sa normal na tao. In other words, na-distort yung normal na function. Okay? Okay. Now, what are the examples of positive symptoms? Okay? Positive symptoms are those that indicate change in behavior or thoughts of the patient, okay, including, remember the code, DH lawak, okay, delusions, hallucinations, looseness of association, agitation, word salad, ambivalence, and confused thoughts, okay. What are delusions? And what if these are turned into layman's again on the test? What if instead of the word delusion, what you have on the test would be statements of patients, okay? Okay. So let's adapt that what if mentality. So, for example, you have an item that says, which of the following are included in the positive symptoms of schizophrenia? Which patient statements reflects this? Select all that apply. Then to reflect delusion, the patient says, bow down, I am the king of England. That's delusion of grandeur. So you put a check. Okay? Hallucination. Instead of hallucination, the patient is trying to position the ears near the wall as if hearing something. That's auditory hallucination, okay? Looseness of association is shifting from one subject to another in a completely unrelated manner. Like the patient being asked, have you taken your vitamins? Yes, the patient answers. I've taken vitamin A to prevent vitamin D, vitamin B to prevent vitamin C, A, B, C, D, E, F, G, I know my ABC, come and join and sing with me. That's looseness of association, okay? Agitation means anxiety with restlessness. The patient keeps moving. The patient keeps pacing. Again, you put a check on that. Word salad would be incoherent mixture of words and phrases. The patient just says anything. Ballpen, microphone, bottle, light, screen, with no sense at all. Ambivalence is the presence of two opposing feelings, love and hate coexisting together. Or an ambivalent behavior would be a patient staying on the doorway, but not making a step to move forward and not making a step to move backward. So the patient doesn't know what to do, whether to go out or stay inside. That's ambivalence. And then confusion or disorientation, okay? When the patient doesn't know what time of the day it is, so you have a manifestation of confused thoughts. Now, those are all indicative of the positive symptoms of schizophrenia. And the medication that targets just the positive symptoms of schizophrenia would be your typical antipsychotics. And an example of that would be your haloperidol or Haldol. Okay? Let's move on. Negative symptoms of schizophrenia are related to loss of normal function. In Tagalog, dati siyang merong function, tapos nawala. So, in English, an example of a negative symptom would be there's a presence of a usual behavior that became lost when the patient developed schizophrenia. Example, the patient used to be interested in outdoor activities, very outdoorsy person, and all of a sudden, the patient lost that interest. That's anhedonia, negative manifestations of schizophrenia. Okay? Now, I'd like to tell you, remember the negative symptoms of schizophrenia. For better or for poorer. for better, no, for richer or for poorer. Okay? Till death do us part, remember the negative symptoms. Okay? So negative symptoms of schizophrenia refer to a loss of previously existing functions, including anhedonia. Anhedonia simply means absence or lack of interest in pleasurable things, including sex. So if your boyfriend or your girlfriend doesn't like having sex, maybe he or she is schizophrenic. Okay. Asociality means reduced social drive. Avolition means lack of motivation. The patient doesn't want to go out. They don't want to interact. That's avolition. Apathy is actually the presence of dulled emotional reaction. They don't have feelings when they speak. And alogia, okay? What does alogia mean? Poverty of speech, or they have absence of logic in the way they talk, okay? Now, take note. One thing I'd like to highlight, all negative symptoms begin with the letter A, okay? But there's an exception. If we move back, ambivalence, and agitation are positive symptoms. Don't forget, even if most that begins with letter A are negative symptoms, agitation and ambivalence are positive symptoms. Okay? Learn how to process. Don't forget. Okay. So alogia refers to poverty of speech. Now, in a patient with auditory hallucination, this is where a lot of confusion is occurring. Most of my students are asking me, sir, what's the right or priority nursing diagnosis for patients who are exhibiting auditory hallucinations? Okay. Is it disturbed sensory perception? Or if the voice is telling them to kill themselves, is it risk for injury? If the main subject would be hallucination, it's always disturbed sensory perception. Then you have to specify whether it's auditory, tactile, or visual. Tactile hallucination occurs in alcoholic patients who feel like bugs are crawling underneath the skin. Okay? So let's summarize. Okay. The positive symptoms of schizophrenia, you have DH lawak, okay? Delusions, hallucinations, looseness of association, agitation, word salad, and ambivalence. Negative symptoms, apathy, anhedonia, alogia, and avolition. Okay. Now, one of my favorite herbal remedies is Ginkgo Biloba. Maybe you could actually consider taking this if you're preparing for the NCLEX and you have poor memory. What does it do? Ginkgo Biloba actually thins the blood, and because it thins the blood, it increases circulation in the brain, eventually diminishing the symptoms of dementia. You know, I have a staff whose mother had dementia, and they're having difficulty locating for her passport. What I did is actually to give her one bottle of Ginkgo Biloba, and halfway through the bottle, eventually she remembered where her passport was. And they've been looking for it for 2 years. But what's the disadvantage? Well, my staff told me, sir, my mother not just remembered where her passport was, but she also remembered, and she asked us who received her cash benefits from the government. Okay. It's going to be the retirement pension that she's receiving. Of course, they can't deny because she already remembered. Okay, so let's begin. So Ginkgo Biloba improves cognitive and cardiovascular function. It may potentially cause bleeding because it thins the blood. And just like any herbal remedies, it's contraindicated in pregnant patients, patients who are due for surgery in 2 weeks because it thins the blood, it could worsen bleeding. It's also contraindicated in patients with diabetes and for those who are taking anticoagulants. So if your patient's taking aspirin or heparin, your Ginkgo Biloba may worsen the bleeding. Okay? Okay. So here's a functional concept. Ginkgo Biloba may help improve memory in clients with dementia. Let's use that functional concept to answer this question. Which of the following patients can safely take Ginkgo Biloba? 29-year-old female patient with positive pregnancy test. We said a while back that pregnancy is a contraindication, so that's not it. So put an X. 30-year-old male patient is to undergo exploratory laparotomy in a week's time. So we said that herbal remedies should never be given 2 weeks before surgery. We can consider. 3, 68-year-old female who was safely rescued from house fire caused by her failure to turn off her stove. Okay, so this one, you have a beginning sign of dementia. Okay, 57-year-old female is currently on aspirin due to her abnormally fast atrial rate. Aspirin's anticoagulant may worsen the bleeding. Here, that's too close for surgery. It will worsen the bleeding. Here, you have a patient with beginning signs of dementia. The question is asking which patient can safely take. So, best answer is number 3. 68-year-old female who was safely rescued from house fire caused by her failure to turn off her stove. Most studies refer to this situation as one of the beginning signs of cognitive impairment, characteristic of dementia. Okay, now let's talk about PPE or personal protective equipment. I'd like to highlight one thing here. This could be very basic, but if you don't know that it's being asked, sometimes you tend to say, oh, anyway, that's basic, I will remember it. But that's not the right attitude if you're preparing for your test. What is important is you have to study whether the concept is perceived to be very basic or whether the concept is something that is actually new to you. Okay, so let's begin. Let's try answering a sample question. A nurse is preparing to put on personal protective equipment. Arrange the steps in order by dragging the steps in column A and dropping them in proper sequence in column B. So this is a drag and drop set of tests, okay? So to answer that question, you have to know the proper sequence. Here's the code, G, M, G, G, okay? When you don it, start with the gown, okay? The gown, the mask, the goggles, then the gloves. Again, G, M, G, G. So the gown, wear it, the gown, the mask, the goggles, and the gloves. Okay. And the proper sequence of removing PPE. So it's gonna be, okay, G, 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 M, H. So gloves, goggles, gown, mask, hand washing, okay? So if it's putting on, GMGG. If it is removing, GGGM, then hand washing, okay? Let's go back to the question. This time, a nurse is preparing to put on a personal protective equipment. Arrange the steps in order by dragging the steps in column A and dropping them in proper sequence in column B. So we're talking about putting on. So GMGG, gown, and then mask, and then goggles, and then gloves. And that's a point, right? Okay, now, some of those things that a lot of nurses fail to study would be basic things like ethical principles. And sometimes even if they study it, even if they memorize the definition, when they're given a scenario or a situation, they are unable to apply what they know. Okay, this time I will make it clear for you guys. So that's gonna be easy for you to remember ethical principles. So let's just deal with the most common ones. Okay. Veracity. Veracity simply means truth-telling. Let me first define before I give you examples. Autonomy simply means the freedom of choice, freedom to decide for oneself, or self-determination and privacy. Beneficence simply means duty to promote well-being of others, doing good for others. Non-maleficence simply means do no harm, okay? Or minimize harm. And finally, justice, fairness. Okay, let me simplify this thing using one scenario that I'm going to revise to show the different implications of each ethical principle. Let's begin. Here's a mother with a baby, and the baby is actually for vaccination. The mother is also for flu vaccination. So the mother asked the nurse, will having the flu vaccine treat flu? So that the word that was used is treat or cure my flu, okay? How would you tell the truth? Tell the mother that the use of vaccines is preventive in nature. It will help prevent you from having flu, but it is not going to treat an existing flu. So vaccines are preventive, okay? If the mother asks, will I have side effects like fever if I have my vaccine? When you decide to tell the truth, yes, you will have mild fever and pain at the injection site after vaccination. That's veracity. Okay, that's veracity. Okay, now using that same scenario, the mother and the baby. So when the mother said, when the mother asked, will I have side effects if I had my flu vaccine? And you said, as a nurse, you will have pain and mild fever. And so the mother said, okay, I'll have the vaccine some other time, not now. And you agreed and said, okay, that's your choice. That's acknowledging autonomy, freedom of choice of the patient. Okay? Now, knowing for a fact when the mother came back for vaccination, knowing for a fact that the mother would experience pain and will have mild fever if she gets vaccinated, but still, you administer the vaccine because it will promote well-being. It will help prevent the flu despite the pain and the mild fever. That's the principle of beneficence. You administer the vaccine despite there will be pain and there's going to be mild fever because it's done to promote well-being of the patient. That's beneficence. Now, when you are injecting, when you are preparing the injection, you notice that the mother whom you are going to inject with the flu vaccine is very thin and have poorly developed muscles. Okay? So you made a conscious effort to choose the smallest needle possible so that to minimize the pain on the mother because the muscles are underdeveloped. So you don't want to do harm. That's non-maleficence. That's non-maleficence. Okay? Now, since you have the mother and the child coming to you for vaccination, the mother has had flu previously and the baby, okay, the child, okay, who is also to be vaccinated with the flu vaccine, okay? Who among the two, who between the two should be given priority if there's only one dose of vaccine left? Will it be the mother or the baby? Since the mother already had previous exposure, it would be more logical if you protect the child who is more at risk and vulnerable. And that's the principle of justice. You are being fair, equitable distribution of resources. So you see, you have one situation that tells us that these ethical principles could be applied depending on the need. So when you're studying ethical principles for the test, avoid canned answers. You have to analyze. For example, if you choose to administer the vaccine using the smallest needle to cause more harm, then that's a representation of non-maleficence. Okay? If you decide to prioritize giving vaccine to the most at-risk patient, then that's reflective of the principle of justice. If the patient asks you, will it be painful if I have the vaccine? And you became honest and you said, yes, you'll have some pain and some fever. That's veracity. If the patient said, I'll just have the vaccine some other time, not now, but I'll be back, and you allow the patient to do that, that's freedom of choice, that's autonomy. Okay? That's how you should remember the ethical principles. Okay, now, once again, let's try to use the ethical principles to answer a question. So here's a sample question. 75-year-old client asked the nurse, am I dying? Which ethical principle will the nurse utilize in responding to the patient? If the patient is asking you, am I dying? Tagalog, mamamatay na ba ako? Huwag ka namang rude na sabihin mo, oo. Okay. So what do we say? If the patient asks us, am I dying? Okay. You have to be guided by the principle of truth-telling, veracity. Okay. So how do you say the truth? You would say, I do not know, but if you want, I can ask your healthcare provider to explain to you your situation. Because nobody knows if somebody is dying or not. Okay? When will you die? Nobody knows. Are you dying? Nobody knows. Nobody exactly knows. Okay? So altruism means being oriented to the good of others. Okay? Altruistic. You do something for the good of others. Okay? Okay, let's move on. Now, here's a more difficult question. And I know some of you might be too lazy to read when you're taking the test and you would say, oh, I'll have a break when a question occurs like this. But remember, when more difficult and more wordy questions like this pops out of your screen when you're taking the test, say hallelujah. Why? It simply means you're progressing to the next level of the difficulty of questions based on Bloom's taxonomy. And that is an indicator that you're going up the ladder of success. Okay, so don't feel bad when a question as wordy as this pops out of your screen. Let's go through it. Okay, so which of the following actions by a nurse demonstrate ethical practice? Select all that apply. Okay. Notifies a healthcare provider about a client's refusal to the physical therapy and his plan to discontinue the treatment. Okay, You facilitated the notification. Yes, that is ethical. Leaves immediately after work, pretending to not have been formally requested to work overtime to attend to patients. So you pretended that you didn't receive the memo. That is unethical. Documents a patient's refusal to try using an incentive spirometry despite several attempts to encourage the patient. Well, you still documented it. So that's ethical. Ask a client to request that the healthcare provider to stay when family matters without relation to any medical decisions are to be discussed. Oh, you're asking the healthcare provider to eavesdrop. Ginagawa mo siyang chismoso. That's not ethical. Tells a client who asks if he's dying, I don't know the answer to your question, but I can ask your doctor to help you understand the situation. This is ethical. Veracity. Agrees to not to file a complaint against a coworker who was seen using narcotics intended for patients after being talked to it. That's not ethical, okay? Because if you choose to remain silent despite having knowledge of what happened, then you become part of the crime, okay? So that is unethical, okay? So here's another sample question. Which of the following scenarios is reflective of veracity? Select all that apply. Veracity means truth-telling. Administering immunization to an infant, that is beneficence. Answering a client's questions with the right facts, that is veracity. Being honest about one's tardiness, veracity. Choosing the right size of catheter for a patient, that's do no harm, non-maleficence. Providing information about a procedures, risks, and benefits, okay? That's veracity. And acting like the client's parents, that's paternalism, not veracity. Okay? Okay, so let's move on. Okay, here's a test-taking key for this NCLEX quick fix session. Believe that you can. As they say, everything seems to look difficult before they are easy. But if you believe that you can, you will. I promise you that. Give it time. And keep on believing, and eventually you will, okay? So remember, your hardest times often lead to the greatest moments of your life. Keep the faith. It will all be worth it in the end. When you get the 4 letters of your name, USRN, and the potential to earn 5 to 7 million a year. Wow. Okay. Remember to always keep the dream alive in your heart and in your mind. Okay, here's another message from Jeneline to inspire everybody. Hey, Sir Ray, sobrang thank you po for everything. I took New Mexico NCLEX in Bangalore, India, and passed it. Sa sobrang hirap ng lectures nyo, even if the lectures are difficult, naging sobrang happy ako habang sumasagot ng NCLEX. I was happy just answering questions on the NCLEX. I'm not being mayabang, okay? I'm not showing off, but it's a fact. Started anxious but finished with ngiting tagumpay. She started anxiously but finished smiling. I stopped at 75 questions. I think SATA was 30, then mostly prioritization, delegation, no computation, okay? I would like to thank all your lecturers and the other profs. All hard work paid off. Every Friday, sacrifice just to attend lectures. Thank you so much. This is Jeneline from Abu Dhabi. Wow. Okay. All the way from Abu Dhabi. Thank you so much. Okay. For the kind words, Jeneline. Okay. Now, let's move on to another very basic thing that most of us would usually fail to study. Okay. Now, let's use our mindset. What about tracheostomy should I study for the NCLEX? Okay, what about tracheostomy? Okay, pay particular attention to the procedure of suctioning. Okay, okay, so let's move on. What are the things that you should know? Let's try answering a sample question. Tracheostomy suctioning are true. Okay. Okay. 1, suctioning may cause hypoxia if done beyond 10 seconds. Yeah, oh, sorry. Before we answer these questions, okay, sorry, we need to have functional concepts, okay? Like helpful hints for tracheostomy care. Take note of the cuff pressure. It should be below 25 to prevent necrosis in the mucosal lining where the cuff is located. Pressure setting for tracheostomy should be between 80 to 120. Suction catheters can be used for 24 hours. tie changes require two competent persons. Always remember to first insert the new tie before removing the old tie to prevent dislodge. Tube changes should be done before meals or at least an hour after meals to minimize aspiration. Okay. Next, hyperoxygenate the patient with 100% oxygen. Don't forget this, before and after suctioning. And the suction catheter is advanced to a maximum of, don't forget this, 6 inches or until the carina or bifurcation of the bronchial tree. Okay, and that's approximately 10 to 15 cm or until resistance is felt. Apply suction for a maximum of 10 seconds. Some literature would say 10 to 15 seconds as catheter is being withdrawn. And you have to apply this intermittently as you withdraw the catheter. And then use distilled water, and in between suctioning, allow the patient to rest for 20 to 30 seconds. Now, let's try to answer the question. Suctioning may cause hypoxia if done beyond 10 seconds. Yes. Pressure setting for tracheostomy suctioning should be 80 to 120. Yes. The suction tube length is inserted should be 5 to 6 inches. Yes. Okay. Suction is applied upon insertion. No. Applied upon withdrawal. Then suctioning is done based on the patient's condition. Yes. Deflate the cuff of the tracheostomy before suctioning. You don't do that, dislodge may occur. Okay. So let's have our what if moment. So tracheostomy suctioning is very basic. So what if something else is asked on the test? So what's our what if moment? Here's our what if moment. Sometimes you will have to go a notch higher, okay? When you study the basic concepts, go a notch higher from the basics. Here's an example. Let's talk about fenestrated tracheostomy. Don't forget this. Fenestrated tracheostomy has one or more hole in the outer cannula. What is the purpose of the additional hole? May butas. To promote normal breathing and speaking as well as coughing. So normal breathing, speaking, and coughing. Okay? So a fenestrated tracheostomy may be used as a step before the removal of the tracheostomy tube. So it's used for rehabilitating the patient in terms of speaking or coughing. A tracheostomy kit is to accompany the patient at all times and must be checked each shift by the nurse caring for the patient. So what should you keep at the patient's bedside? An extra tracheostomy kit. Why? If the patient's tracheostomy gets dislodged, you have to have an extra kit to immediately insert. Otherwise, there's going to be a problem on the patient's airway and breathing. Okay? So what about if the tracheostomy kit is not clean? The problem of infection is just secondary to airway. Even if a perceived complication would be a complication, for as long as you maintain patency of the airway, that's all right. Because even if you're talking about or thinking about infection, so you did not actually insert the tracheostomy kit as early as you can. So what happened was eventually the patient died. So it's better to have infection, but the patient's able to breathe rather than preventing infection, and then the client is unable to breathe because the tracheostomy got dislodged. Okay? So test taking key, always ask what if. We've been doing that since session 1, right? Always ask what if, what if, what if. Okay. Okay. Here's one very basic thing. What is a primary consideration? How do you position a car seat in the car? These are a lot of confusions been occurring among nurses who are taking the NCLEX. The key is, there's only one. Okay. What's the primary consideration in terms of the positioning of the car seat for infants? Is it the height? Is it the weight? Is it the age? What is the priority consideration, if you'll be asked? We'll answer that as we dig deep into the discussion. Okay. So remember this functional concept. Correct use of infant and child car seats entails avoiding the top 3 errors. The first error is that the seat's not tightly secured to the vehicle, so it actually moves, okay, more than 2.5 centimeters in any direction. Harness not snug, okay, and chest clip not at armpit level. Okay, sometimes the chest clip is on the abdomen level. That's not proper because eventually the child's chest and head will not be protected when bumps occur. Okay, so rear-facing car seat should be used until children weigh at least 10 kilograms and at least 1 year of age and able to walk. So you have 3 criteria: at least 10 kilogram, 1 year, able to walk. The position, rear-facing. In Tagalog, yung upuan nakaharap sa likod, like this. This is the back of the car. This is the infant car seat. So the face of the infant is facing the back of the car. And this position is used, take note of the 3 criteria, when the child is at least 10 kilograms or 20 pounds, at least 1 year, or able to walk. Okay, next. Forward-facing infant child car seats may be used for children between 10 kilograms up to 48 kilograms, 10 to 22 kilograms or 48 pounds, up to 122 centimeters in height, depending on the manufacturer specification. So, when do you position the infant's car seat towards, okay, the front part of the car? When the child, look, is between 10 to 22 kilograms or up to 122 centimeters. Okay, so rear facing if the child is below 10 kilograms, forward facing if the child is between 10 to 22 kilograms. Don't forget. Okay, then booster seats should be used for children who have exceeded the weight or height limits of their forward facing car seat and weight, or at least 18 kilograms. So this is your booster seat. You use this if the child's seat is no longer appropriate. You use what we term as the booster seat. You get a lot of fines in the US if you don't use this in your car and you have kids on board. Okay? So booster seats should be used for children, once again, who have exceeded the weight or height limits for their forward-facing car seat. Okay. Seat belts may be used for children who are heavier than 36 pounds or at least 8 years of age. So remember the rule 88. You use seat belts when a child is already 80 pounds or 8 years old. So 88. So when will a child begin to use a seat belt? When they're 80 pounds or 8 years old. So 88. And who properly fit the adult restraint in the vehicle. Therefore, let's answer my question. What is the primary consideration for the position and use of car seat? Is it the height? Is it the weight? Is it the age? And the primary answer is, it's present across all age groups, the child's weight. So yung primary consideration, that's a priority. Okay, when you're deciding how to position the infant car seat, consider the child's weight. Clear? Yes. And when can children use the seat belt? Remember the 88 rule. 80 pounds, 8 years old. Clear? Okay, good. They're learning. So the most significant indicator of appropriate seatbelt precautions for children is the weight. Okay. Now, this is another procedure that a lot of us don't seem to see as very important when preparing for our test. Once again, because it's very basic. Okay. Now, when you say ear irrigation, this is actually the flushing out of some debris that could have collected inside the ears, and this could actually entail the use of water, not necessarily sterile, but of the right temperature. Okay, so ear irrigation is the process of flushing the ears with a liquid to clean and remove foreign particles, usually carried out by a nurse. So we begin with washing the hands, then ask the client to sit with the head tilted over to the side, the bad ear pointing down. So if it's the right ear that's a bad ear, it should be tilted towards a small bowl. Instruct the client to hold a small bowl or basin under the bad ear. Fill the bulb syringe with warm water. Open the ear canal by holding the outer ear and pulling it back. So if you have a child, pull the ear down and back. If you have adults, pull the ear up and back. So usually, if you have age demarcation, 3 years old and above, up and back. Below 3 years old, down and back. Why is that so? Because children below 3 years old have their ear canals wider, straighter, and more horizontal. That's why the proper way of pulling it is down and back. Okay, so position the bulb syringe towards the ear canal and squeeze the bulb to apply steady stream of solution towards the top of the auditory canal, using just enough force to remove what is inside the ear. Now, how could these steps of a procedure be transformed into a question? It's like this. Okay, a nurse is about to perform ear irrigation on a client with impacted cerumen. Arrange the steps of the procedure by dragging the items on column A and placing them on column B in the correct sequence. So we begin with, okay, washing the hands, and then instruct the client to hold a container under the bad ear and then fill the bulb syringe with warm water, and then pull the ear back to open the ear canal, and finally, flush the water into the ear canal using a bulb syringe. Okay? So if you know the steps of the procedure, it's easy. Now, when you're reading procedures, it's very, very important that you do it to yourself and you try to demonstrate it to yourself in front of a mirror so that you remember it. Remember, if you're doing it, you remember it better. Okay? Now, let's move on and let's talk about fluoxetine. Okay? So fluoxetine is actually an SSRI. So it's actually an antidepressant. Okay? The first thing that I'd like you to know about fluoxetine would be three things. Okay? The first one would be the side effects. Side effects could be gastrointestinal, so you have nausea, vomiting, diarrhea. It could be neuropsychiatric. The patient may have insomnia in their nervousness. And the most common concern of patients who are taking fluoxetine, it could be sexual in nature, in which they could have premature ejaculation, or the patients would complain about failure to have erections. Okay? That's common in patients who are taking fluoxetine. Okay? Also, remember that fluoxetine is the only SSRI that increases 3 neurotransmitters. That's your SND, serotonin, norepinephrine, and dopamine. Because some antidepressants could only act on 2 neurotransmitters, either serotonin and dopamine, or serotonin and norepinephrine, but never serotonin, norepinephrine, and dopamine. Only your fluoxetine does that. Okay? So pay particular attention to the neurotransmitters that are being increased by fluoxetine. Okay, now let's talk about alcoholism. Now, once again, a lot of nurses are asking me, sir, when I study alcoholism, what do I need to study? Will it be the definition of alcoholism, the risk factors for alcoholism? Forget about those things, guys. Focus on the assessment of alcoholism. And if we talk about assessment of alcoholism, think about the CAGE questionnaire. Okay? So remember, alcoholism is not defined based on frequency and amount of alcohol intake, but on the effect of the alcohol on one's function. Okay? So, when admitting a client with history of alcoholism, asked, have you ever felt you should cut down on drinking? Have people annoyed you by criticizing you? Have you ever felt bad or guilty due to your drinking? And have you ever had the drink first thing in the morning, drinking as an eye-opener? So you have CAGE, the CAGE questionnaire. Now, let's have our what-if mentality. What if what was asked on the test would be a SATA format question, which is asking you, which of the following questions should you ask when assessing an alcoholic patient? Will you ask the patient, have you ever felt annoyed? Okay. Have people annoyed you by criticizing you? Or have you ever felt bad or guilty due to your drinking? Or have you ever had the drink first thing in the morning? Okay, put a check on all those. But if an item says, will you need to ask the patient, how much alcohol do you drink? Or at what times in the day do you drink alcohol? No, you don't need to ask those questions because, take note, alcoholism is not defined based on frequency and amount, not even at the time of the day when you drink the alcohol. It is based on the effect of alcohol on your functioning as represented by the CAGE or CAGE questionnaire. Clear? So you don't ask an alcoholic, how much do you drink? They may pretend to drink a little less. Don't ask them, at what times of the day do you drink? No, okay? That's not part of the CAGE questionnaire assessment for the alcoholic patient. Clear? Okay, now, let's have our what if moment. Okay, what if you have a pregnant patient who is at risk for alcoholism and you would want to assess alcohol drinking behavior of the patient during pregnancy? Will you still make use of the CAGE questionnaire? No. So the CAGE questionnaire is not used for pregnant patients. The questionnaire used for pregnant patients is called the TWEAK questionnaire. TWEAK, TWEAK. So what do you ask? Tolerance. Are you needing increasing amount of alcohol during pregnancy? That's tolerance. W, worried. Okay. Does it worry you that you're drinking alcohol while you are pregnant? E, eye opener. Do you drink alcohol first time as you open your eyes in the morning? And A, amnesia. Do you forget things when you drink alcohol? And then K, cut down. Okay, do you feel the need to cut down on your alcohol drinking? So remember, the TWIC questionnaire is a modification of the CAGE questionnaire. Okay? So here's a sample question. Let's apply what we learned. Because if you don't know how to apply, it's going to be difficult. So which of the following questions is appropriate to ask an alcoholic client during admission interview? Have you ever felt the need to cut down? Yes. Remember, cut down. Has anyone annoyed you? But yes. Okay, annoyed. Do you have any guilt feelings? Yes. Okay, this is included. Do you feel the need to drink the moment you wake up? Yes, that's eye-opener. Okay, how much alcohol do you drink in a day? What did I tell you a while back? You don't ask the alcoholic this question, so we put an X. Okay, clear? That's how you study your concepts. You always think, what if? How are these concepts going to be manifested when it's being asked in the form of a question? It's useless knowing and memorizing all the data, and you don't know how to reflect on those data, and you don't know what to do with those things that you have memorized, then it's not going to help you out in the end. Okay, so let's move on. Now, what if this time a patient, okay, who is an alcoholic gives birth to a child with FAS? That's your fetal alcohol syndrome. Okay. Now, there are things that a lot of you guys could be thinking. What should I study when I'm asked about fetal alcohol syndrome? Once again, what's the first step in the nursing process? Assessment. And assessment would tell us to deal with the symptoms. How would you know that the child is having fetal alcohol syndrome? We begin. You have microcephaly or small head. Well, microcephaly is found in trisomy 18. It's also found in trisomy 21 or Down syndrome. Okay, so in fetal alcohol syndrome, you have microcephaly. Then you have wide set eyes. So the space between the eyes are so wide. Okay, thin upper lips, receding chin, and of course, hyperactivity. Okay, so you have an ugly baby. Okay, small head, wide set eyes, thin upper lip, receding chin, and hyperactive ugly baby. Okay, so if somebody asks you if your mother is an alcoholic, what does that mean? You're ugly. Okay, so let's move on, okay? So let's pay particular attention now on how do we use this information or data to push our dreams of becoming a USRN, okay? Let's move on. Ginger, okay, this is one of the herbal remedies again that I'd like to highlight. Aside from Ginkgo Biloba, the similarity would be that Ginkgo and ginger could actually potentially increase bleeding. Okay, but ginger is usually used as a digestant. Any one of you have not seen ginger? I'm pretty sure I wouldn't believe that somebody have not seen ginger pa. Ano ba yan? If you haven't seen ginger, remove your shoes, remove your socks, you're gonna see one. What you're gonna see if you remove your shoes and socks would be an example of ginger. Okay, so let's move on. So your ginger is used as an antiemetic and anti-inflammatory, and it's used in the treatment of burns, ulcers, colic, hypercholesterolemia, impotence, and indigestion. So ginger may increase the risk of bleeding when used with anticoagulants. It may also antagonize antihypertensive. So here's a sample question. Which of the following patients can benefit from the effects of ginger? 15-year-old complaining of colic, 61-year-old patient with atrial fibrillation is taking aspirin. Remember, it may cause bleeding, so no, we don't give it with aspirin, an anticoagulant. 42-year-old patient with disseminated intravascular coagulation taking heparin as part of her treatment, no. In disseminated intravascular coagulation, we have bleeding as a result of systemic clotting. Heparin is given despite the presence of bleeding in disseminated intravascular coagulation because the cause of the bleeding is the systemic clot formation. So heparin will prevent the systemic clot formation, thus it will decrease the bleeding in DIC. But since the patient is at risk for bleeding, we don't give ginger. Okay. 4, 55-year-old clients suffering from hemorrhagic stroke. Hemorrhagic stroke, there's a risk for bleeding. Ginger increases the risk for bleeding? No. So the best answer is definitely A. 15-year-old complaining of colic because ginger is used to treat indigestion. Okay. Now, here's one thing we have to brace ourselves because I'd like to differentiate DKA and HHNK. So Diabetic ketoacidosis and hyperglycemic hyperosmolar non-ketotic coma. Okay. Now, first, let's identify. In both conditions, there's usually hyperglycemia. The main difference is that the sugar level. So if you have 300 to 600 milligrams per deciliter of sugar, suspect DKA. The patient will usually manifest with Kussmaul's breathing. If the patient has more than 600 milligrams per deciliter of blood sugar, suspect HHNK. Therefore, if you are not given a symptom, if you're not given a diagnosis and you're just given a group of symptoms and the patient had a history of diabetes, go to the sugar level right away so that you can pinpoint whether a patient is developing DKA or HHNK. So another difference, type 1 diabetes mellitus leads to DKA, while type 2 diabetes mellitus leads to hyperglycemic hypersmolar non-ketotic coma. So DKA is characterized by blood glucose level of 300 to 600, while HHNK is characterized by blood glucose level of above 600. So what are the signs and symptoms common to both DKA and HHNK? The three Ps, polyuria, polydipsia, polyphagia, because both conditions reflect hyperglycemia, plus nausea, vomiting, weakness, weight loss, and confusion. So in both DKA and HHNK, you have confusion. You know, once I had almost a DKA episode, okay? My blood sugar really showed up when we were like eating. Okay? Next. Signs and symptoms that differentiates DKA. In DKA, you have fruity scented breath that's not present in HNK, loss of appetite, acetone breath, abdominal pain, Kussmaul's breathing, and shortness of breath, okay? Now, signs and symptoms that differentiates HHNK, seizures and coma, and GI complaints. Therefore, if a patient has hyperglycemia, sugar level above 600 with seizures and coma, think HHNK. If the patient has blood sugar level between 300 to 600 with fruity odor of breath, think DKA, okay? And for both conditions, the priority is to normalize the sugar level. Rapid-acting insulin is usually given. Now, infection is the most common cause of DKA, and administration of fluids is the primary treatment of DKA. Okay, now one of the complications of diabetes is actually the presence of gangrene. That's why it's very important that you know how to instruct your patient to take care of their feet. Okay, now what if the NCLEX would ask, what will you tell a patient with diabetes to facilitate foot care? Okay, so proper diabetic foot care includes instructing the client to avoid going barefoot, even at home. Don't go barefoot. Avoid using of sandpaper to remove corns. No. Okay, you don't do that. Avoid using lotion in between toes. Yes, they can use lotion on the feet, but not in between toes because it becomes a culture medium for bacterial growth. Being observant for cuts, bruises, and signs of nerve damage, and cutting the toenails straight across and filing the edges, okay? Don't allow them also to use stone, okay, to remove the corns, okay? Always instruct them about A, B, and C, okay? So let's move on. Test-taking strategy, understand and reflect. Never, ever just have a superficial read. No. Read deep, okay? Always remember, deeper is better. Deeper is better, okay? Let's move on. Wow, we're moving on to some of the disorders that might really be difficult to understand. Okay, so let's move on to hyperthyroidism, sometimes labeled as Graves' disease, Basedow's disease, or Paris disease. Okay, so when you talk of hyperthyroidism, it's very important if we go back to the thyroid hormone, T3 and T4. If there's a deficiency, what results? Hypothyroidism, which means there's going to be decreased vital signs, gastrointestinal movement, and decreased response in terms of mood. But there's going to be increased sleep. So if you see a patient who is very fond of sleeping, assess for hypothyroidism. However, if there's thyroid hormone excess, think about hyperthyroidism, in which there will be increased vital signs, gastrointestinal tract movement, so there will be diarrhea, and of course, irritability in terms of mood response. But they will have decreased sleep and decreased menstruation, thus amenorrhea is typical of hyperthyroidism. Don't forget that amenorrhea is typical of hyperthyroidism. Okay? So what are the signs and symptoms of hyperthyroidism? Fine hand tremors, like a side effect of lithium, intolerance to heat, nervousness, emotional stress. You have the code FINE. Then heat intolerance, exophthalmos or bulging eyes, arrhythmias, tachycardia. Then you have heat, the code heat, and then diarrhea, acropathy or soft tissue swelling, and excessive sweating. So day. So you have one, fine, heat, day. Okay. So here's how a patient with hyperthyroidism look like. You see the acropathy in the eyes, soft tissue swelling, and then exophthalmos, bulging eyes. Okay. So thyroid crisis is actually a complication of hyperthyroidism. So it's characterized by increased temperature and heart rate, okay? And it could occur after surgery or when there's increased stress. Okay, therefore, if a patient with hyperthyroidism suddenly manifests increased temperature and increased heart rate, then that's a medical emergency. That patient is your priority. Okay? Okay. So thyroid crisis is characterized by heat, hyperthermia, emotional swings, arrhythmia, and tachycardia. That's why in thyroid crisis, the priority is to prevent possible development of stroke or atrial fibrillation. And so the patient would usually be given like beta blockers. Okay. Okay, this is how a patient with thyroid storm would look like. Okay. So thyroid storm is manifested by which of the following? So this is an example of a question that deals with this concept. What did I tell you? Hyperthermia, yes, we put a check. Rapid heart rate, yes. Arrhythmia and congestive heart failure, yes. Stupor, irritability, and restlessness, yes. Hepatomegaly and mild jaundice, yes. And muscle rigidity, no. Supposed to be muscle weakness, okay? Okay, now, this is one of those neglected concepts that some of you might not be so familiar that I'd like to highlight. It's pheochromocytoma. So pheochromocytoma is actually tumor of the adrenal medulla. Okay, so most of the questions that deal with this would actually ask you either to prioritize or play with questions that would ask you to choose the correct response in a SATA question. So let's begin our discussion. Don't forget, this is going to be easy. Okay. So this is actually an illustration of the tumor location of a patient with pheochromocytoma. So it's on the adrenal gland. So the adrenal are actually your glands on top of your kidneys. That's why it's called adrenal. Okay, so pheochromocytoma means there's a tumor of the adrenal medulla. Now, for us to be able to understand what are the symptoms that are associated with pheochromocytoma, you have to know what's the function of the adrenal medulla. The adrenal medulla actually secretes your fight or flight hormones, and these are your epinephrine and norepinephrine. So if there's going to be a tumor in the adrenal medulla, there's going to be an increased secretion of epinephrine and norepinephrine. This will actually increase the vital signs. Therefore, which vital signs most severely affected? Don't forget, it's a potential question. The blood pressure. So in pheochromocytoma, elevated BP is a priority. So your priority should be monitoring the patient's blood pressure. However, there are symptoms, group of symptoms that represents pheochromocytoma, and I termed in the 5H. Okay, so you have hypertension, headache, hyperglycemia, hypermetabolism, heavy sweating. Okay, so hypertension is the priority. Monitoring the BP is the priority for a patient with pheochromocytoma. Don't forget. Okay. Okay. So hypertension, headache, hyperglycemia, hypermetabolism, heavy sweating. Okay. So key points, always remember, when there's sudden onset headache, usually severe of varying duration, coupled with high blood pressure, abdominal pain, rapid heart rate, pale skin, and sweating, remember sharps, suspect Pheochromocytoma. Then eventually, you have weight loss, anxiety, force for heartbeat, and feeling of extreme fright because of the increased secretion of epinephrine and norepinephrine. Okay, you have that in your handout. Okay. Wow, I know somebody was dreaming that I will take up Cushing syndrome. Okay, Cushing syndrome and differentiating it with Addison's disease. Okay, so your wish is my command. So wish granted. Okay, so let's talk about Cushing syndrome. Do you still have the energy, guys? I just hope you have to at least, okay, keep up with me today. So surely with your feedback, give me feedback. We would appreciate it on how we can improve this so that the next session on October 3 would benefit you the most, okay? And then tell your friends to join us, okay? So, Cushing syndrome. So in Cushing's disease, you have to remember there is overactivity, okay, of your adrenal glands, okay? Now, the adrenal glands have two main parts. You have your adrenal cortex and adrenal medulla. Okay? We talked about the tumor of the adrenal medulla a while back. Now, let's talk about the problem when there is a tumor in the adrenal cortex. Now, we all know for a fact that your adrenal cortex produces your glucocorticoids and mineralocorticoids. When there's a tumor in the adrenal cortex, there's going to be overactivity of the adrenal cortex. So what do you have? Cushing's disease. So in Cushing's disease, we have increased glucocorticoids and increased mineralocorticoids. Question: what are the functions of glucocorticoids and mineralocorticoids that could give us an insight about the symptoms or the pathology in Cushing's disease? So remember, glucocorticoids controls usage of sugar. Therefore, in Cushing's disease, since you have increased glucocorticoids, you have increased sugar. So there's hyperglycemia. Mineralocorticoids retain sodium and excretes potassium. Therefore, in Cushing's disease, since you have increased mineralocorticoids, then you have increased sodium retention. So you have hypernatremia and increased excretion of potassium. So you have hypokalemia. So in a patient is having hypokalemia, okay, sorry for the interruption. That's when technology falters here in the Philippines, okay? Okay, so let me go back again. So, since in Cushing's disease, you have increased mineralocorticoids, you have increased sodium retention, so you have hypernatremia, and increased excretion of potassium, so you have hypokalemia. So, if a patient with Cushing's disease, okay, would manifest muscle weakness, it's expected because it's associated with the hypokalemia, okay? Also, when you're giving diuretics to patients with Cushing's disease, be mindful that diuretics who are not potassium sparing may worsen hypokalemia. Also, when you're feeding the patient with Cushing's disease, supplement their potassium, so increase potassium. However, okay, you may want to hold back on their sodium. So you don't give salty foods to patients with Cushing's disease because it will worsen hypernatremia. So what are the electrolyte imbalances that may potentially occur with Cushing's disease? You have hyperglycemia, hypertension, hypokalemia. The hypertension could be a result of increase in sodium that retains fluids, increasing the blood pressure. So therefore, what should be the goals of care? Normalize the sugar, normalize the blood pressure, normalize the potassium. Okay, so anything that may worsen this should be avoided. Okay, so let's use the concepts. Okay, so what happens in Cushing syndrome? You have, because of increased sugar, weight gain, slow healing of cuts, okay, increased risk of infection, fatigue, glucose intolerance, okay? And then because, again, of increased sugar, okay, so you have truncal obesity, punctuated by moon face, buffalo hump, and of course, muscular weakness. Then the skin becomes thin and fragile, and there's excessive hair growth or hirsutism and stretch marks because of truncal obesity. Okay. In females, there's irregular or absent menstrual periods, and females, erectile dysfunction. Okay. The bones may have increased risk for fracture, and then the blood pressure may go up, as I've told you a while back. Psychologically, because of their appearance, it leads to anxiety and depression and loss of emotional control. So they have, take note, emotional lability. They are irritable. Emotional lability because of hormonal imbalance. Okay? And that ends our session 2. We still have session 3, which will come up